Shot. All right, welcome. It's Dr. Deuk. We're shot. Getting ready to perform a cervical Deuk laser disc repair, AP, on a patient who travels from where?
Pensacola, Florida.
Oh, all the way from Pensacola. Lateral. He has a herniated disc at C6-C7. He is a bodybuilder. He is absolutely humongous. Neck shot. Wait. Shot. Shot. I'm just going to keep it there for a second. Rest my fingers. All right, 2. Let's count. 2, 3, 4, 5, 6, 7. So we're at 6, 7. He has a herniated disc, AP, at C6-C7. He has an incredibly thick neck, one of the thickest I've ever seen. And we've just managed, perfect center, I love it, managed to get the needle into the 6-7 disc. We weren't sure we were going to be able to. I have to try to advance it. Try to get the other shoulder. Shot? Sure. All right, that's good. Shot. That's good. Yes. Shot. All right, I'm going to do a discogram. Good. This patient did not want a fusion. He was recommended for ACDF. Shot. And the truth is, perfect. We're good. You can see the tear in the back of the disc. Jordan, show us that. You can see the dye leaking out through the tear where the herniation is. So we've successfully gotten into the 6-7 disc thanks to my amazing team and our anesthesiologist. Again, his neck is the neck of a football player, 100%. That makes it really hard. That's good. So we weren't sure, and I told the patient before surgery, as well as his wife, there's a 25% chance I will not be able to do the surgery because your neck is too thick. I always tell my patients there's a chance I can't do their surgery. They need to know that. It's true for any surgery and any surgeon. But in his case, it was particularly true because he has such a thick neck. All right, Henry, let's talk about why do people get neck pain. You know, herniated disc is one of the causes of neck pain, but not all of them. And people can have a herniated disc. That's about 85%, 90% of chronic neck pain. Shot. Okay. The other causes include facet joints. I'm going to take this needle out. I'm going to leave the guide wire. And I apologize in advance for the view of the x-ray. We have literally the very best x-ray in the world. It's a Siemens intraoperative fluoroscopy machine. And what is it again? A Siemens C6-C7. It's top of the line. They don't have a better one. But even with the best in the world, we still have trouble because the thickness of this patient's neck and shoulders make it very difficult to see. Shot. As I'm navigating the dilator down, you can see the guide wire within the disc space at 6-7. 2, 3, 4, 5, 6, 7. Shot. And I'm placing the dilator between the carotid artery, jugular vein, trachea, and esophagus. And I'm almost to the front of the disc at 6-7. I am now at the front of the disc. I can feel it. What I'm feeling is the anterior longitudinal ligament, or ALL. We've lost 2 drops of blood. Perfect. Shot. All right, I can take the guide wire out at this point, but let's get one x-ray front back. In the meantime, Henry, let's show the audience how is it that a disc herniation actually causes so much pain in the neck. Welcome back. Shot. Yep. And again, what makes this surgery so difficult is number one, it's C6-C7, which is the bottom disc in the spine. It's in the neck. It's the hardest to get to. Number two, super thick neck, football neck, makes it really hard. Number three, the clavicle is right here. It's pushing my tube up. So it's right here, pushing on my tube and trying to push it up, which we don't want it to push up, because if it pushes up, then I can't get the tube in. It'll be pointed downwards, and we need it to point backward, not downward. All right, and you see from our video that the disc does cause pain, and the way it causes pain is via inflammation, right? That's it, inflammation. Can someone help me here? Let's see, shot? I think I got it. There we are. Good. So we're now in the front of the disc with the tube. Folks, the entire surgery, instead of an ACDF fusion, we're doing an endoscopic surgery. We're going to clear out that herniation. We won't get 100%, but no surgeon can get 100. That's beautiful, Jordan. We will get probably 75%, 80% of the herniation, if I'm lucky. Worst case, 50. I've never gotten less than 50. I think 50% is the minimum you want to get. In the neck, it's a little bit easier than the back, because in the lower back you have, it's much harder. You have to go both sides to get the whole herniation, but in the neck you can go in the front and then get both sides. Shot? All right, just about done. Perfect. There it is. The tube is all the way to the back. We're ready. So we're going to take the dilator out. I dropped the Raytech. But look at this right here, guys. This is his chest. That's the tube. His chest is literally touching the tube. That makes the surgery harder. His surgery is very, very difficult. On a scale of 1 to 10 for endoscopic cervical spine surgery, it's a 10. And thank God there's people here helping me. You can see we've lost like 5 drops of blood, but it's really pushing against his clavicle. You guys see that?
Yes, we do.
I mean, if this was the next disc down, it'd be impossible. It really is impossible. There aren't many surgeons, probably the only one in the world that would do this. But he really didn't want a fusion, and he really wanted laser. So I made a commitment to him that I would do my best. Now we're gonna have to hold the chest down because it's gonna push against this. I need to reduce the brightness of the light. It's too bright.
3 down, please. Yeah. Thank you.
Now, we're not out of the woods yet, by the way. We are just starting. One more. This is the herniation, by the way, right here. And we are already working on the herniation. But I can tell you his chest is pushing against my scope. And it's really making it very hard for me to do my surgery. So just getting to the disc was an act of God. And then getting the herniation out will be act of God number 2. Any questions?
No current questions, so we do have a comment coming from Jason on YouTube.
Jason, is this Jason after Jason or just Jason?
This is Jason Goodman on YouTube.
Hi Jason, welcome to our stream.
Saying, put me on the list. I'm not a meathead, I promise.
That's so funny. You got it, man. We'd love to put you on the list. We're going to have to switch the irrigation to the other side because I cannot fit the irrigation against his chest. That's the tightness of the space we're working on. But thank you, Jason, for considering it.
We have a question
Yes.
coming from the classic Carnut on YouTube.
Yes, the classic Cardinal. Welcome.
Saying, hi, have you heard of the disc seal procedure, an injection that uses the fibrin to encourage disc healing that repairs annular tears? Any thoughts? You are doing great work. Thank you.
Thank you so much. Yes, of course, we know all about this seal. It does not work. It's a piece of garbage surgery. I would not recommend it to anyone. It's one of those things that sound good but aren't good. because they don't work. We've had so many patients that have had disc seal. Probably 60 patients that we've had to do surgery on. They had the disc seal already. It didn't work. I would not recommend it. Doesn't work. If it worked, we'd do it. It doesn't work. But you're welcome to try it out and find out for yourself that it doesn't work, and then come to us. There is a herniation. You guys see that?
Yes,
So
we
the
do.
there's another one. The beauty of this surgery is we can actually see the herniation, and there's where the herniation is pushing on the spinal cord, right there. There's another piece jiggling around like a little lottery ball. Do they even have lottery balls anymore?
That's a good question.
Remember the old lottery machines?
Yeah, I don't think.
On TV, when they did the lottery, they would have that machine. There was another herniation and another herniation and another herniation. By the way, disc seal would never do this. Disc seal procedure cannot remove herniations. All it does is put some junk in there. Somebody makes a shit ton of money selling it to you, and then it doesn't work, and they go, oh, well, we tried. At Deuk Spine, we don't tell people, oh, well, we tried, because either we did it or didn't. 5 minutes, Dr. B, 5 minutes. And I don't do surgery that doesn't work, just so you understand that. I don't believe it's ethical to do surgery on patients that we know isn't going to work. And disc seal doesn't work. So I would never do it. I would have to like hit my head and suffer permanent brain damage to my frontal lobe and basically become a real bastard of a doctor to recommend disc seal or other treatments that we know doesn't work, and just prey on people's ignorance and their hope. And I'm not that kind of guy. I do surgery that works. This surgery works. It works every single time. We've never had a failure. All right, I guess I'll go a little further. Yes. We've had reherniation, but we've never had a failure. Guys, we're almost done. The good news is we found the tear. Henry, why don't we show the audience how the Deuk laser disc repair procedure works in the cervical spine.
Copy that.
Welcome back. So you see how the Deuk laser disc repair works. One of the things we do with the lasers, we free up the pieces of herniation that are stuck by scar tissue from inflammation to the wall. And there's one right there. There's a big piece of herniation. You guys see that?
Yes, we do.
That thing is like 6 centimeters long, 4 centimeters wide. Here you go. So I just pulled that out of the tube. I'm giving it to Luis so he can take it home and feed it to his dog. Just kidding. But in all seriousness, that's really how the procedure works. The big pieces that I can't get out because they're too big, we have to go in and grab them out. All right, we're just about done. You can see all the herniation back here is now gone. There's the posterior ligament right there, posterior longitudinal ligament. There's a little bit of herniation still on my side. I need to explore that tear back there. You guys see the tear?
Yes, we do.
Mm-hmm. So I'm going to go out to the foramen, make sure there's no herniation in the foramen. and then I'm gonna, let's go ahead and flip it. Mm-hmm. Oh, it's fine. Hey, at least it wasn't my shoe this time, right? Just kidding. So, any other questions?
Yes, we got a couple of questions. This next two coming from Sylvie on YouTube,
Hello, Sylvie. Welcome. We're almost done.
asking how long
Tell me
will
again.
the patient be out of work after the surgery, and also can the herniation come back after the surgery?
Yeah, so Sylvie, the herniation does not come back. It comes back in 1% because they don't follow the instructions. They re-herniate. And that can happen with any surgery. It doesn't matter what surgery it is, but the re-herniation rate is much higher with other surgeries. It's very low with this surgery, the lowest you can possibly have. He can go to work tomorrow. He can go to work tomorrow. That's how quick the recovery is from this surgery. He can go to work tomorrow. All right. That's where the herniation punctured, and I have to go clean that area up just a little bit more. Just take a look at it. You can see there's another puncture there. There's another piece of herniation. So I got to open up the posterior ligament and check the epidural space. That's what I'm doing right now. I don't expect there to be too much, but there will be some. You can see all the scar tissue there. There is some herniation right there. By the way, this is a better view than you get with ACDF. Dr. B, I told you 5 minutes. It's going to take me a couple more minutes. More pieces of herniation. See how many pieces of herniation have come out? I lost count. It's over 10. But a lot of people think herniation is one piece. It's actually a lot of pieces. And this patient is no exception. Before you do that, let's just see if we can make it work. Okay, push on his chest. Sometimes I can. All right, so far everything is going well for the patient. We're just about done. I've just got to make sure we're not leaving anything here. Man, that is another piece right there. What we're doing, by the way, when I come up the tube is I'm floating out the herniation. I'm removing it by literally letting the irrigation pressure bring it up and out the tube. Now, some pieces are too big. You can't do that.
We have a couple more questions.
Sure, I'll take the questions.
Next one coming from Riley on YouTube. Riley asked, why is his chest pain a problem with the scope, like tightness-wise?
Because the angle of the scope is pushing down against his chest. I can't get in. It's physically blocking me. That's why. His chest is literally so big, it's physically blocking the scope from going down. You see? It's just, I can't get it down anymore. Because it's also C6-C7. 6-7 is the lowest disc that we operate on. It's the closest to the chest. And people with a huge chest, I mean, if it was like a breast of a woman, it would probably be okay if it was soft because you can kind of mush it down. But with a muscular chest of a bodybuilder, it's almost impossible to mush it down. He's got solid muscle. I think we're done. I just want to see if I can get in here. I don't see any more herniation there. I just can't reach it. But I don't see any more, so I think we're okay. By the way, the view spine surgery, you only get this view with the endoscope. There is no other way to get this good of a view. So when people talk about endoscopic surgery versus non-endoscopic surgery. The endoscope gives the surgeon the very best view of what's happening inside. This is scar tissue right against his spinal cord. It's quite interesting. There's a little bit of a bone spur, and it's not pushing on the spinal cord, but it's blocking me from getting to this material. So I had to take the bone spur down with the laser. Let's see if there's any more. This is the posterior ligament, and to me it looks like there could be a little bit of herniation behind it, so I'm going to take it down. This laser is so sensitive and so accurate and precise. It's literally peeling away 1/20th of a millimeter, 1/20th. There is no surgical tool in the world that is that precise as the laser. The laser is the most precise tool. This is very old stuff right here. You see how it's calcified? This is an old herniation, really old right here. Dr. B, I'm almost done. I literally have this one last piece and we'll be done. But this thing is an old herniation. And it's right up against the spinal cord, literally embedded. I can't get 100%. I'm not going to try. That could cause a complication with the patient, which I don't want. But I've gotten about 60%, which is really better than any other surgery. If you have ACDF, you're not going to get 60%. You're going to get maybe 30, 40%. All right, let me just rotate a little bit. See if I can get 1 or 2 more percent down there. Any other question?
Yes, these next two questions both come from Cindy on YouTube. Asking, do or can you correct spondylosis? And also, what is the cost of the surgery without insurance? Is there a list that I can get to verify the insurance you accept?
Yeah, Cindy, first of all, there's no list that tells us if your insurance will pay or not. We won't know until after we do your surgery. Insurances will often say they'll pay, and then they don't pay. And so we can't run a company on promises of payment because my employees won't work for promises of my payment and not payment. So what we do is we look at your insurance. If your insurance is willing to sign a contract saying they'll pay, then you don't have to pay anything other than what they say you need to pay. But other than that, there's going to be an out-of-pocket. It really depends on your insurance. We are done. That looks really good. I've taken out as much as I can safely. We've probably got 60%. We need 50% to have a good result. So I think he's going to be fine. And as far as cost, I don't discuss costs because I don't know the costs. I just come and do the surgeries. The costs depend on what procedure you're having, how many discs you're fixing, how many levels, which levels, cervical, thoracic, lumbar, are there facets, is the SI joint. So there's a lot of variables. If you want to know what it costs, then you need to do an MRI review, which is available on our website for free. Once you've done that, then you'll know exactly what your costs will be because we'll take into consideration the insurance and everything else. Okay, you guys see this? This patient otherwise would have had an ACDF anywhere else in the world. That's what you guys are all being recommended for is cervical fusions. He didn't have to. We were able to get in his disc. That's his Adam's apple. He's got a super thick neck. He's a bodybuilder. The incision is 4 millimeters. It's outpatient. He can go back to work tomorrow. He actually is from Florida, right?
Panama City is not Panama.
We lost, 3 drops of blood? 3 drops of blood. So this is pretty much bloodless surgery. There's no metal. There's no fusion. There's no artificial disc. And the incision is just 4 millimeters. 4 millimeters. Okay, let me show it to you guys. You guys see this?
Yes, we do.
All right. All right, so we lost 5 drops of blood. Go ahead, I'll hold it for a minute while you... Scope use is a 6. Any other questions, Henry?
Yes, just one final question coming from Jason once more on YouTube, asking, do the foraminal calcified osteophytes cause as much pain, numbness, and etc. as herniations?
No. Foraminal calcified osteophytes cause 0 symptoms. 0. None. Anybody that tells you different is lying to you. It's the herniations always that cause the problems. All right. Great to be with you. You guys have watched the most advanced disc surgery in the world. It's going to replace ACDF, cervical fusion, artificial discs. But unfortunately, most surgeons have no clue how to do it. They've never been taught. It's an advanced technology. They haven't learned yet. So be smart. Do what's best for you. Don't just go and do what your surgeon tells you. Do your research, do your homework, learn the truth, and do what's best. That's what this patient did. We have people from all over the world that come here because of our endoscopic laser surgery. They don't want to live in pain, and they don't want metal or plastic or cadaver bone or stem cells stuck in their body. This is all natural, and we probably got about 60%, 70% of that herniation. I feel really good about it. Thanks for joining us. We'll be back shortly with one more cervical Deuk laser disc repair and Deuk plasma rhizotomy.
Before we conclude, we just have one final question that is coming from Cindy asking if you could treat spondylosis.
Spondylosis we can treat, yep, with the laser. That's right.
Beautiful. All right, and that is it for questions.